So my name's Katie Hards, and I'm one of the senior diabetes specialist nurses in Northamptonshire, and we're a community-based team, community-based multidisciplinary team. And we came into fruition back in 2011, and I was lucky enough to start with the team at that point. And so the money to enable us to become a community-based specialist team came from a change in prescribing. So we released money from a prescribing budget to allow us to invest in that stage. And the objective was to improve care in the community, closer to home, for people with predominantly with type 2 diabetes, although as you can imagine, the world has changed somewhat. And we now see a lot of people with type 1. But with what had existed beforehand in Northamptonshire was a team in the north of the county in sunny Kettering, who had been working sort of quite autonomously, doing bits and pieces. Some were GP surgery, some were the consultants, a little bit at the hospital, and they had within that team some support workers. Now I believe if you're in Leicester, support workers will be something that you're quite familiar with, but for me, I'd come from Oxfordshire at that point. It was a role that I wasn't familiar with at all. And the team in its infancy was very, very keen and very wisely right to invest in this role. And I felt that I could take today's opportunity to talk about that journey. And actually, with the two girls that are sitting here with their heads down, hoping that I'm going to shut up in a minute, how without them we wouldn't survive as a team and their patients would be absolutely bereft. So we started back in 2011. Originally their role was to go and see people at home, check that they could do their insulin, check that they were washing their hands before they did their glucose, and could they maybe remember to take their insulin. All of the routine challenges that we often see, but they were able to go and see them at home. Also the plan was for them to do some of the routine checks, although that got sidelined slightly. But as a new service, we had a bit of time to play with, so it was all quite nice. So a couple of years later, when the service was starting to become very well established within the county, the volume of referrals and a lot of the collaboration that we do is with our district nursing colleagues predominantly, but also we see people independently of any other healthcare professionals other than being registered with the GP. So what tends to happen now with the girls is that I'm saying girls because we haven't got any boys on the team, is the referrals come in, and if it's appropriate for the girls to go and see these patients at home, they will do, because neither of the girls are qualified nurses, or none of the girls are qualified nurses, and we've got 7, 8 in the county now. They come in and they're triaged by a DSN, and they're then delegated to go and do an assessment visit out in the patient's home from that point of view, and they do a full detailed assessment from that point of view, and then they feed back to the DSN that's referred them. And we use an integrated system called System 1. Anybody else familiar with System 1? So it's a clinical system, yeah, so you tend to have EMIS or System 1. We've got System 1, so all of the data is visible to the GPs and to us and to other healthcare colleagues within the trust. And we share their knowledge and do a lot of it virtually. We've got mobile working within the trust, so the girls have got little tablets that they can input in the patient's home, so they can send a message, assuming the 4G is working, to us, and they can get pretty much an instant message, which is a bit what we were talking about earlier, that's speedy, let's make a difference, care happens on the ground. And as time's gone on, experience, the networking, the girls in the role refer to GPs, to consultants, to podiatry, to social services. Who else do you speak to? Anybody and everyone, the Falls team, all of the integrated teams for those vulnerable group, but alongside the clinical delivery of patients' homes, they also do a huge amount of education. So Anna is a lay educator for Desmond. From that point of view, we do healthcare professional education for our residential home training, which has been made bespoke for the trust. We do some of the healthcare professional education, and the team help at that level. So although you could argue you're not qualified nurses, they're functioning very much, and the expertise that you've got is fantastic. You've integrated in the team, they work alongside us, with us, they tell us what to do sometimes, which is even better from that point of view, but they pick up those things, and we're able to see people from the early part of diagnosis, certainly at pre-diabetes, because we do a huge amount of work at pre-diabetes, right the way through to the end of life. And at the moment we've got a lot of palliative patients on our caseload, and we're aiming and helping people have a dignified death at the end of their life with diabetes, which a lot of us will know is very, very difficult. It all sounds lovely, rosy and wonderful and easy, of course, she says with great confidence. And it hasn't always been. Obviously, the natural anxiety of the role, how it fits, what we did with it, how we support people, and that's the biggest challenge that we've got, which is ensuring there's enough supervision, support and access so that the decisions can be made safely. To be a support worker in Northamptonshire, you have to be quite persistent, I would say. That if you want an answer, you just find someone to give you an answer, but we respect the team so that they do give us that. They do get the answer they need when they need it, which is the important bit. Regularly they get supervision from within the team. We meet, we do caseloads. They carry their own caseloads so they know who they're working with, and we can see that if they go on holiday or sick or anything like that, we can pick up those groups of patients. And we involve them in, we send you to Diabetes UK, you're part of the team, so it's very much an integrated, and it's a really collaborative approach to what we do. And all I can say is that I'm incredibly proud of the journey. We've used the competencies from Trent to support that journey and evidence it, part of their appraisals, the training, the education. I am incredibly proud of the journey that the girls have taken from the very beginning to now, and to a certain extent the future will look much, much better with them and their role in it. We did a poster for the Queen's Nursing Institute last September, and again celebrated what the role does and what it brings, and the patients get the care they need in the place they need it. And when they don't need to be seen at home or they move, they come back into clinic. So it's a very fluid relationship from that point of view as their healthcare changes. But I think I speak for the whole team saying that without you and without them, we would be very stuck. I'm a bit like a proud mummy from that point of view, but they are. So two of the girls are here today because I think it was really important to bring them along to celebrate them, because it is. But it's that NMC, it's that delegation, it's being sure that you've got the processes in place to ensure the safe practice. Has anybody got any questions?
I want one.
You want one? I have to say, I was a little bit cynical. I wasn't sure at the very beginning, but I have to say I wouldn't, as a community DSN, be without them in my team now. I cannot say enough.
I think it would also take some pressure off district nurses, because sometimes you assess someone, know what's needed, but you can't go, even if it's teaching someone to glucose monitor and the time it takes, it's good to have that.
We try and do a 6-week overlap with the district nurses for those new discharges, new to insulin, that the girls will go in and see if that person could be independent at the end of it to keep them off the DN caseload, if at all possible. So, and it's that overlap with the skills and expertise. Certainly people with dementia, those memory problems, all of that stuff that is our type 1s, making sure they've got keto meters, all of that stuff is done. And it is just...
So in the initial stages of an injectable therapy initiation, is it you guys that would go in if they needed home visits rather than the district nurse?
No, the district nurses would pick it up because we just do Monday to Friday, but we'd go in with the education support and go in and back up what's happening from that point of view.
And what's the ratio of DSN to support workers? So there was 7 of them in the
Yeah, so we're a whole county, so Northamptonshire is sort of long and thin.
Yeah.
We've got, I can't remember off the top of my head, this, George is doing the maths in
I can only think of 6.
Yes, we've got 2.
3 are in the county.
Yeah, we've got 4 good people also. So we've got, they're not all full-time equivalents, but we've got 14 DSNs, so it's about 50.
Yeah.
So
I can.
So what about titration of doses? Because that's an area, isn't it?
So what we tend to, the girls will give us the information, and there'll either be a clear plan, like a clinical management plan on there, or they'll come back with specific, this is what I've got, what do you want me to do next? And because we're on system 1, we can type it in and it's evidenced all the time straight away from that point of view. So we do a lot of that, and it is all of those things that you have to have in place. Without the mobile working, you'd be stuck. And it's slightly different in a hospital setting, which is why from a community setting it is absolutely ideal. We can cover so many more people from that point of view. So we do, and sometimes if somebody's come out of hospital and they're poorly at that point of discharge, then we can get them on track quite quickly. Of course, the problem is we also pick up a lot of the inappropriate discharges too. So it's quite a good window of what's going on. And we do help people not go in. So sometimes they're able to avoid a lot of that work.
Do you think you're quite unique in Northamptonshire with what you're doing there? Are you aware of it happening anywhere else?
I'm not aware of it to the level we've got it, which is partly why I wanted to bring it to the fore today, because I think from a community, community now specialist, much as I'm going to leave that, but as a community now specialist, I'm really passionate that it's an entity on its own. It's different to being the hospital side of things, and I think as a service we were one of the first to be a community MDT, and I think this is we're now long enough in the tooth to be able to say it works and this is why it works.